Hey there, curious minds. Ever wondered if drugs are inherently bad, or how to get a loved one hospitalized when they refuse to go, or how psych nurses handle coworkers with mental health issues? Today, we're diving into a variety of mental health questions you've been asking, and who knows, if you continue watching, we might just uncover the answer to some of your burning questions that you didn't even know you had. We've got a whole lineup of questions to tackle in this video, so if you've asked a question and I said that I would make a video about it, there's a chance I'm addressing it here. Check the timestamps in this video description to see if your question is answered, and you can just do that by looking up your name and the YouTube handle, and then that's where your question will be. And if I missed your question despite promising to answer it, please just remind me. Life's been like a little hectic and I tend to be a little forgetful, so I need all the help that I can get. Before we dive into our first question, I want to give a huge shout out to all of you who have been just supporting my channel over the last few years. You're the reason that I keep creating content like this. I'm almost at like 3,000 subscribers, and I have a video that I think has like over 17,000 views, which is kind of crazy when I think about it, because that's like enough people to fill an entire stadium full of people. And I think that was the video where I talked about antipsychotics and side effects. So that's kind of cool, just like kind of neat, I think. So without further ado, let's get into our first question. First up, we got Miss Kareen. She asked about a combo of Midazolam, an opioid, and Haldol, which is an antipsychotic being used for patients with COVID. And I'm not a COVID expert, but I did find some articles confirming these drugs are used for end-of-life care, or that combination of drugs is used for end-of-life care. And what really caught my attention was that a lot of these involuntary movements caused by antipsychotics can affect pretty much any muscle group, including those that are used for swallowing and breathing. And by the way, my kids are playing upstairs, so if you guys are hearing background noise, that's what that is. And it's really easy to forget that antipsychotics affect all these muscles because they're just hard to see. And so nurses like me often worry about respiratory depression when we see this mix of medications. However, it seems that in some cases, like terminally ill patients with COVID, this combination is still used to manage pain and agitation despite the risk. Apparently, agitation is quite common in those with severe COVID infection. So, Kareen, I feel like I might be missing something here about your comment. So if you have more information, please feel free to leave another comment below. Next up, we have a question from Daniela, who wonders if antidepressants don't work, what else should we do? And I think that's a great question. And this was in response to a video I made by a psychiatrist who's not a big fan of antidepressants. Her name is Dr. Kelly Brogan, and she has some interesting insights. She suggests that depression isn't a chemical imbalance, but is instead linked to chronic low-grade inflammation and our immune response. And she recommends treating depression through pretty much just diet and exercise. For example, she suggests a 30-day whole food challenge where you only eat things like fresh fruits, vegetables, whole grains, legumes, nuts, seeds, unprocessed meat, fish, poultry, and minimally processed dairy products. And then after that, you slowly reintroduce your regular foods into your diet to see how your body reacts. She's also a big fan of the paleo diet, and don't forget about daily exercise, even if it's raining outside. Now, aside from Dr. Brogan's take on depression, here's a thought. What if depression isn't entirely negative? What if there were some positive aspects to our depression? I challenge you, Daniela, and anyone else struggling out there with depression to find what might be some positive aspects about your situation and about your depression. Mental states aren't purposeless. They have meaning, and it's really up to us to find out what that meaning is. Our next question is by Troy. He asks, how do you break up fights between patients as a nurse? And while I haven't seen many fights as a nurse, Troy, I can share a little bit of insight. One time I just used kind of a loud and authoritative voice, and that was enough to kind of snap two patients who were about to fight out of it. And then after, I was just like, stop. And I said it really loudly, and I got their attention. And in that time that I had their attention, I chose the patient who I felt was a little more redirectable, and I redirected him back down to his hall, into his wing, into his room. And we had a little discussion, and then I talked with the other patient, and then we kind of as a treatment team came up with a way to prevent that from happening in the future. I also had a coworker who at another hospital stepped in between two patients and told them to stop. And she had really good rapport with that aggressive patient who was coming towards the other patient. I don't necessarily recommend that because I just feel like it's very dangerous. And as long as you try to de-escalate it and you're doing something proactive, you've really done your part as the nurse. And the reality is, mental health patients, a lot of them know what they're doing when they are about to fight, excluding those who are severely psychotic. And so I guess the reason I'm saying that is they're grown adults making a voluntary decision, just like two people who sign up to fight in the UFC. And I'm not saying that I'm condoning violence or that we should just let it fly or anything like that. I'm just saying that you can only control so much as a psych nurse. And as long as you try to de-escalate it, that's pretty much as much as you can do. And then I would also say that if you feel like you notice patients getting a little agitated, try to prophylactically offer them a PRN so that you're addressing the behavior before it becomes a huge concern, if that makes sense. So the go-tos would be like, you could use something like Vistril, Benadryl, low-dose antipsychotic for patients who are aggravated, or something like a benzodiazepine like an Ativan or Klonopin, something like that. Our next question comes from Shantae, and she asks about handling coworkers who might themselves have mental illness and how to do it in a professional manner. And while I may not be the perfect source on this, Shantae, I'm still going to share my thoughts. And what I would just say is, like, generally we want to assume the best for everyone that we work with and try to just approach topics sensitively and gently with people who work in mental health. And just, I would say, kind of keep in mind that everyone who works in mental health probably has a stressful personal life and may be sleep deprived. And then when we discuss sensitive topics, try using I statements to express your feelings. For example, you could say something like, I feel worried when I hear you use that tone with a patient, and I'm a little concerned it might aggravate them and lead to a dangerous situation. And the theory behind these kind of I statements is that when you use an I statement and you talk about your feelings, it's supposed to build connections with the person you're talking to because they can find it relatable. Now, whether or not that actually works, I'm not entirely sure. I try to use it and I've had some success with it. And then other times I'm like, I don't feel like that worked that well, but maybe you'll have a better approach. I'm not the most tactful person. So, and then something else you can try that I've read from like just kind of a number of books, and I feel like they all sort of say the same thing, is just try to be genuinely vulnerable with people and share your concerns just with a lot of compassion and openness. And remember that hurt people hurt, and there might be something going on in someone else's personal life that's causing them to behave the way that they're behaving. Not that we're justifying it, but usually there's something else that's going on. So just try to have as much compassion for your coworkers as possible. And then lastly, I would just say something that's kind of worked for me is just trying to go with the flow and keeping your opinions to yourself unless you just see something that's so egregious you feel like you need to speak up. And then just kind of be by being present on the unit, you can provide patients with a compassionate ear and support. And I hope that helps. Shantae, you didn't provide a ton of details in your situation, so I'm just kind of offering some general advice here, and hopefully you find this helpful. Our next comment comes from Skater Kid, and he talks about missing a court date. He was a inpatient due to the lack of alarms on the psych ward and not being woken up by staff, so he misses his court date. This is an unfortunate situation, and I feel like it kind of highlights the challenges patients face in accessing adequate legal representation within a psychiatric hospital. And I feel like oftentimes the patient is sort of viewed as incompetent, while the psychiatrist is viewed as this rational and impartial expert witness. And it creates this weird dynamic where the psychiatrist and the patient kind of seem to be at odds with one another, even though the psychiatrist is legally bound to have the patient's best interest at heart. And there are definitely situations or examples I can think of where the psychiatrist and the patient may not really see eye to eye on what's best for the patient. And I feel like it's very just essential for the psychiatrist to deliver their testimony in a compassionate way, even if what they believe is different from what the patient believes is in his best interest. And it really needs to be done with compassion, especially like when the patient is sitting right there inside of the courtroom. And I guess I also feel like it's important to acknowledge that many psychiatrists are probably jaded by the field and might benefit from just a break so they can kind of recharge their compassion. I think working in mental health can just be absolutely taxing, especially if you've done it for many years. And my hunch is that a lot of their compassion has just kind of waned over time. And again, I'm not trying to justify the lack of compassion that they have. I think it's just important for us to remember as patients, as whomever, that psychiatrists like us are just people. We're all just people trying to make it in this world. Another thing I want to point out is, imagine if we were a patient in this situation and the person who is supposed to help us and guide our treatment is kind of adversarial, and that's the only person that we can depend on, and they're the one guiding our entire treatment, just how that might make us feel. I think that would just absolutely suck. Imagine being an inpatient and you cannot stand the psychiatrist, but you can't choose to work with anyone else. Like, it's super frustrating, and I wish there was somehow a third party that could kind of oversee things, but I don't think it's ever going to happen. It's just too resource intensive, and our culture has not placed a huge emphasis on treating mental health yet. We're getting there. We are getting there. Things are improving. It's just a slow process. All right. Our next comment comes from Christopher, and he shares his experience taking SSRIs, selective serotonin reuptake inhibitors, and antidepressant, which he took for 10 years before they stopped working and then started causing him agitation. And although he needed them for a specific situation, they became ineffective, making him feel restless and agitated, as if his body was now rejecting the medication. And it's uncommon for someone to experience this after years of taking a medication. And the first thing I think about are these paradoxical reactions, which typically occur within the first few weeks of treatment. So paradoxical reactions are when people experience the opposite of the expected effect from a medication. For example, like if you take a medication that's supposed to sedate you, and instead of being sedated, you're agitated, or someone who takes an antidepressant for suicidal ideation, and instead of having less suicidal thoughts, they now have more suicidal thoughts. Those would be examples of paradoxical reactions. Christopher, I feel like in your case, that's what's happening. It's just so weird that it's happened after 10 years like that. I couldn't find anything when I did some research. I couldn't find any paradoxical reactions that happened after 10 years. It's usually within like the first 6 weeks of treatment. Christopher, there's also some people who believe, and there's some research that supports it, that taking antidepressants for a long time can make depression worse, because the body might start to work against the drug and stop it from being as effective as it once was. And there's a whole lot of physiological things that happen when we take an antidepressant. I mean, it messes with all of our neurotransmitters. Our receptors for the neurotransmitters are affected. The way we metabolize the drug is affected. And all these changes over time can maybe ultimately lead to a situation like yours, where you're taking the antidepressant and now it's like, oh my God, it's doing something totally different from what it used to. So some of these changes may be permanent, and perhaps that's why you're going through what you're going through, Christopher. And unfortunately, I couldn't find like a lot of research that really offered any sort of suggestions as to what you're due once you're experiencing one of these paradoxical reactions, if that's what you are in fact experiencing. So I would definitely say that we need further research, and it'd be nice if you could find a provider who you trust and who listens to you and maybe could provide some insight into your situation. Our next question comes from Sham and focuses on how to ensure a loved one remains hospitalized when they truly need it. And when a loved one is admitted to the hospital, I would just recommend contacting the psychiatrist to provide an accurate account of their relapse and situation. I feel like sharing your frustration about the cycle of your loved one being in and out of the hospital can help provide context for their care. And then, of course, you want your loved one to sign a release of information for any and all information, so that you can contact the hospital and talk with the psychiatrist, the treatment team, the social worker, and discuss what their treatment looks like and their discharge plan, so you can stay in the loop. And that way, if they plan to discharge and you're like, whoa, wait, I feel like this is premature. Can we look at maybe this option or this option before they just discharge them and they're back out on the streets? And it's like this whole rinse and repeat thing. And Sham, unfortunately, what you mentioned in your comment, especially after I worked outpatient, is super common. Typically, a person needs to be a danger to themselves, to others, or be unable to take care of themselves, and this has to be a result of a mental illness before they're involuntarily committed. And sometimes the professionals responsible for these decisions may not have the same perspective on your loved one as you do, making it very crucial for you to be in contact with them, to give them all the updated information and really share with them your perspective on the event. So Sham, I am like crossing my fingers for you that you found this helpful and that it'll somehow be used in a beneficial way for your loved one. Our next question comes from Crystal, and it's about the number of competency evaluations patients undergo before a decision is made regarding their competency. And just a quick filler here: when a patient ends up in the jail and they seem like they might be psychotic or out of touch with reality, Oftentimes the jail will send them to a psychiatric institution to have that institution evaluate their competency, because we wouldn't want someone who is completely out of their mind to sit for their charges, whatever legal charges they have, because it just simply wouldn't be fair. So the jails will send them to an institution so they can have their comp evals. And Crystal's wondering all about comp evaluations. So here's my answer. So if a patient is deemed competent, they will typically have just one evaluation, after which they return to jail or prison, and then they will face their charges. If they're incompetent, then they usually have another evaluation within about 3 months. This process continues until they finally pass their competency evaluation. And in the interim between those, or in that 3 months, the treatment team is going to try to educate them on the legal system and what their rights are, things like that. And hopefully in that 3 months, they'll also be speaking with their attorney. They will continue these competency evals every 3 months until either their charges are dropped or their time spent in the psych ward would equal the time they would have spent if they were guilty, served if they were guilty, if that makes sense, or they are considered permanently incompetent to proceed. If they're permanently incompetent to proceed, then the treatment team and the judge will determine the best course of action for that particular patient. Our next question again comes from Crystal, and she asks why it's so hard for hospitals to find psychiatric nurses despite relatively good pay and fairly easy work. And I would say, Crystal, there's a number of reasons for this. I would say that just in general, there's a shortage for nurses across all fields. Psychiatric nursing doesn't appeal to many nurses who value their hands-on skills and worry about losing them in this field. The third reason I would say is that psychiatric nursing is like a very distinct type of nursing, and a lot of nurses, when they went into nursing school, didn't imagine themselves becoming a psychiatric nurse. I would say a fourth reason is probably safety concerns. I'd say that psychiatric nursing is arguably the most unsafe field for nursing. Maybe ER and detox are similar. And I think safety is a huge concern for a lot of nurses. So that's probably another reason. Another reason would be like just many nurses prefer to be busy and kind of work a lot. And I know that kind of sounds sort of weird, but a lot like psychiatric nursing just has a different pace. Maybe I shouldn't say busy, but a lot of nurses I feel like just like a moderate pace when they're at work. And sometimes psych nursing can just be very, very boring, and you're just sitting down watching patients, and that just doesn't appeal to a lot of nurses. Another reason I think is just the field is like highly people oriented, like with staff and with patients. And some nurses, after years of being in nursing, may just kind of feel jaded and overwhelmed by constant people interaction. And so I don't think psych would be a great fit for them. And I would say these are just like a few of the reasons I can think of. I'm sure there's many more, but yeah, those are the reasons that I got for now, Crystal. Our next question comes from Mr. Jim, who says that he's noticed a change in his granddaughter after she started taking some psychotropic medication. And Jim, my initial thought after reading this comment is to question the validity of changing someone's diagnosis while they're on a medication, a psychotropic medication, as I feel like it introduces an additional variable that needs to be considered. And maybe the provider did already do this. I don't know. This is just my initial thought. And if I were diagnosing, I would be concerned that my diagnosis might be influenced by how that medication, in this case, the antidepressant medication, is affecting that person's behavior. And now I'm seeing a different person. And so now my diagnosis is changing, if that makes sense. I guess rather than just it being like an organic diagnosis. So I would really wonder how that antidepressant affected your granddaughter such to the degree that she now has a diagnosis of bipolar disorder. And then I would say when approaching her parents and how to talk to them and all that, you could just start by voicing your concerns and asking how they feel about her being on the medication and what they've noticed. And then I would also discuss the changes that you've noticed and observed, and then just asking what their thoughts are. And then from there, just kind of see how the conversation progresses, kind of play it by ear. And as far as treatment goes without medication, healthy diet, good exercise, supportive social network, and then sleep. I would say just a very, very good sleep hygiene are probably the most important things. And maintaining regular contact with her to see how she's doing, and just asking open-ended questions in a non-judgmental way to really get a feel for where she's at in life, and just being that supportive person, I think would probably go a long way as far as treating her depression. Our next comment comes from Jimmy, who discusses methamphetamine use. And Jimmy, I agree that meth is far more dangerous when smoked or injected, particularly if needles are dirty or if the meth contains unknown chemicals. Smoking and injecting essentially delivers a substance directly into the bloodstream, bypassing the liver's metabolism and making it far more potent than if we were just to ingest it. You mentioned the idea of responsible drug use, and after reading Drug Use for Grownups, I believe that meth can absolutely be used responsibly if it's clean and the user maintains a healthy relationship with the drug, which means, listening to their body's needs and using it in moderation. I think many patients run into trouble with meth when they misuse it, leading to sleep deprivation, poor diets, severe psychosis, and then eventual hospitalization. And ultimately, it's the user's responsibility to ensure that any drug that they use is done in a responsible manner. And so, Jimmy, I want to thank you for sharing your perspective on methamphetamine use. Our next comment comes from Afura33, who mentions the severity of withdrawal symptoms and from psych meds and how some psychiatrists just seem to kind of dismiss these issues or downplay them. And it's true that there's some psychiatrists who may be far removed from the user experience of psychotropic medications, especially if they themselves have never experimented with any of these medications. And while not every psychiatrist needs personal experience with these drugs to be an effective psychiatrist, they could benefit from a better understanding of their effects to provide more compassionate care regarding side effects and withdrawals, in my humble opinion. And I feel like if they were to take the drugs themselves, they would probably have more compassion for the people that they prescribe the medication to. And I remember reading quite a number of articles back in the 1950s. And psychiatrists back then, I don't want to say this is like the norm, but it seems like a number of them were experimenting with themselves with psychotropic medications to understand what the drug actually did, because you can sit there and read all you want, and until you've actually had the med in your system, you're not really going to know what it's like. And then just regarding your whole comment about tapering, it's often more challenging to reduce smaller doses, such as going from like 10 milligrams to 5 milligrams rather than from like 100 to 50 milligrams. And that seems to be a pretty typical response from people who try to taper off of, say, like benzodiazepines. If they're on 10 milligrams of Ativan, they do okay. But then when they get down to that like 2 to 1 milligram, that's when a lot of people, for whatever reason, really start having a difficult time tapering off of the meds. Our next comment comes from Kim, and she discusses a person who she saw taking multiple psych meds who had an insatiable appetite. And it's concerning, especially when drug manufacturers aren't forthcoming about the side effects. And while many people are obese without taking antipsychotics, and there are some people who have an insatiable appetite without taking antipsychotics, I mean, these medications cause incredible weight gain. And it's unfortunate that even when the meds are effective, I still feel like there's a decent likelihood that they're going to cause horrible side effects. I just wish we had something that was effective and didn't have all these nasty side effects, because then we could all rejoice. It would be just freaking amazing. Our next comment comes from Janet, and I found this comment just to be absolutely beautiful. I'm going to withhold my commentary on this one and just let the comment speak for itself. And I really encourage everyone out there to read this comment in its entirety. But here's a quick summary for those of you who might be listening to this episode while driving and maybe you can't read it for whatever reason. So Janet talks about how many people seeking mental health care are often trauma survivors, often from childhood sexual abuse. She then mentions how, unfortunately, mental health care providers sometimes dismiss their trauma and experiences as delusions, leading to further victimization. This can result in over-medication, making individuals more vulnerable and unable to defend themselves or recognize danger. And Janet continues by saying these drugs can also impact one's ability to work and be productive, often causing apathy and accidents. And in some instances, these medications can destroy one's health, one's career, and trust in others. Janet says the Me Too movement highlights the prevalence of sexual harassment and assault in our society. And trauma survivors still face human rights violations in the mental health care system, which is kind of a double whammy. First, you get traumatized outside of the system, then you go into the system, and now you're traumatized again. Janet continues, it's important to recognize that psychiatric abuse and gaslighting of trauma survivors must be addressed and prevented. Janet continues, healing from trauma requires time, good nutrition, a healthy lifestyle, exercise, a supportive community, and loving care. And she says that the withdrawal symptoms from various psychiatric medications can mimic mental illness symptoms, leading to even more medications and increased decrease mental health issues in our society instead of relying solely on medications. Janet says, consider exploring other options such as online resources like YouTube and online therapists, and be cautious about seeking mental health care that may lead to further abuse or the loss of your achievements. And Janet wants to emphasize that, remember, you ultimately have the power and agency to heal and thrive without these medications. And I just want to say, Janet, thanks for this comment. I feel like it is just absolutely beautiful and kind of sums up how I feel about our healthcare system as my baby is crying upstairs. Well, that about wraps it up for our super long conversation. I'm looking at the time here. I'm like, this video is like extraordinarily long. I want to thank you all for sharing your thoughts and engaging in this meaningful conversation. And remember, I read and appreciate every comment that's on my channel, whether or not it aligns with my perspective. It doesn't really matter. I'm aware that so many people have differing viewpoints out there. It's kind of cool to have a place where I feel like you can just submit a comment and not really care about what people think. And that's kind of one of the goals of my channel, is just to have like a place where people who feel like they've been traumatized or have mental health issues or whatever can just voice their concerns without feeling overly judged, if that makes sense. And I also feel like we have a number of people who might be watching right now who are kind of lurking. So I encourage you to have a voice and just leave a comment below and share with everybody else what your experience with mental health has been like. And please, if you have any other further questions or comments you'd like me to address, leave them below and I'll do my best to try to get to them. Some of you guys were sitting on these comments for like months, so thank you so much for your patience, and I will see you on the next vid. Bye-bye.